Okay, so moving on to loop diuretics, general information. Loop diuretics, they work on the ascending loop of Henle, where 20% of our sodium is reabsorbed. So again, I have here a picture of the nephron, just in case you forget. So the ascending loop of Henle is this bit here. Again, 20% of our total sodium is reabsorbed here. Loop diuretics are, they can work in low renal function. Actually, they are the drug of choice for moderate to severe renal failure because they do not alter the glomerular filtration rate. So they're, they're good even if your kidneys are not functioning very well. They're rarely used alone because they trigger compensatory mechanisms, and which I will explain later, and they have kind of a very short duration of action. So yeah, they're not used alone. They're used for hypertension specifically if thiazides are like inadequate, so they have the synergistic effect with thiazide diuretics. So examples include furosemide. Furosemide has a vasodilatory action, specifically venodilation, which is dilation of the veins. Furosemide, from what I've read, they have no direct vasodilator effect on the arterioles actually. So if you give furosemide IV, then it might provide quick relief for symptoms, in left ventricular failure, and it might resolve pulmonary edema. So torsemide is another example of a loop diuretic. So among all of this, it has the longest half-life. So that might be an MCQ question, I don't know. So just remember, torsemide has the longest half-life in all of the loop diuretics. So we have bumetanide as well, which is the most potent one, the most potent loop diuretic, and it has less adverse effects compared to furosemide. And then lastly, we have ethacrynic acid. So ethacrynic acid is highly toxic. It's toxic mainly to the ear, it's ototoxic, and to the auditory nerve, so it's actually not used that often. Mechanism of action. So loop diuretics, they block the sodium-potassium 2-chloride symporter. So we have a different symporter here, guys. Bear that in mind, and I will discuss this in the next slide. They also produce prostaglandins, which have vasodilatory effect. So this means that NSAIDs would reduce their function because non-steroidal anti-inflammatory medications such as ibuprofen, they block the production of prostaglandins by blocking the COX enzymes. So just remember, NSAIDs would reduce the function of loop diuretics. They would make them less efficacious, basically. So effects. As I said, loop diuretics, they are very powerful. They are the high-seating diuretics, which means that they create, the maximal diuresis effect, the maximum water loss. And they decrease calcium reabsorption. They produce hypocalcemia, in contrast with our thiazide diuretics that increase calcium reabsorption and actually produce hypercalcemia. Okay, so now let's discuss the mechanism of action of loop diuretics. So if you've seen my previous video, this diagram would kind of make sense, but I'll just repeat myself anyway. So here in blue, we have the cell membrane, or the membrane of the lumen. Here we have the ascending loop of Henle, and here it signifies that we've kind of moved downstream from the ascending loop of Henle into the collecting duct, or the late part of the distal convoluted tubule. So here we are in the ascending loop of Henle, and here in green we have our little cells, and in pink we have our peritubular capillary, and between the peritubular capillary and our cells we have the interstitium. Okay, so this is the apical membrane. So basically it's the membrane of the cell that's orientated towards the tubule, which is this bit. And here we have the baselateral membrane, which is the other membrane orientated towards the peritubular capillary. So as you can see here, we have loads and loads of different channels, co-transporters, ATPases. So let's start. Okay. So in a normal physiological setting, we have our sodium-potassium 2-chloride symporter, or co-transporter, whatever you want to call it, here in the apical membrane. So what it does, it brings in sodium, potassium, and 2-chloride into the cell. Okay, so what happens is that the sodium concentration inside the cell builds up, So how does the cell get rid of that, extra sodium building up in the cell? So our little guy here, it's still here, our sodium potassium ATPase. So it pumps the sodium out for the exchange of potassium into the cell. So it pumps 3 sodiums to be exact, and then it pumps in 2 potassium ions, okay? So that's what happens to our sodium. So now what happens to our chloride ions? So chloride ions, they keep building up in the cell because, through this symporter. So some of the Cl ions, they actually leak out into the interstitium and then eventually reaching the peritubular capillary, reaching our bloodstream. And then with potassium here, so potassium builds up in the cell as well because we're actively pumping it in for the exchange of sodium, and it's coming in through this sodium potassium 2 chloride symporter. So the increased concentration of potassium means that some of them, they leak out into the lumen or into some leak out in the peritubular capillaries as well, as depicted here. So when they go to the lumen, because they are positively charged, they create a luminal charge, they create a positive luminal charge. So if you imagine lots of potassium coming out into here, right? So we increase the charge here, we make it more positive. So here we have, in our filtrate, we also have magnesium and calcium, our divalent cations. So our divalent cations, positive and positive, they repel each other. They don't want to be together. So that means that our magnesium and calcium, they just go back into the bloodstream because they want to avoid that positive charge, okay? Okay, so now let's discuss what happens when we give loop diuretics. So loop diuretics, as we know, they inhibit the sodium potassium 2 chloride symporter. So they inhibit this symporter on the apical membrane. So what does that mean? So that means that there's less sodium that's transported inside the cell. So we increase sodium here, right? Because it's not coming in. And then we also have less chloride coming in. So we increase our chloride concentration in the filtrate. And then we also have less potassium. So we increase potassium here. And we decrease the concentration of these 3 ions inside the cell, all right? And less potassium means less potassium inside the cell means less potassium leaking out into the peritubular capillary or leaking back. And that means that there is no positive luminal charge created here. So the charge is actually neutral. So that means that our divalent cations, our magnesium and our calcium, they don't get reabsorbed into the capillary. They just stay in the filtrate because there's no driving force for it. There's no reason for them to leave because the charge is neutral. So then what do we get here? So in the peritubular capillary, we have a decrease in sodium, we have a decrease in chloride, we have a decrease in potassium, and we also have a decrease in magnesium, so we get hypomagnesemia, and we get hypocalcemia. Sorry, my handwriting is just atrocious today. I'm using my mouse to write, that's why. So anyway, so that's what we get in the peritubular side, inside the peritubular capillary. We get a decrease in these ions, these electrolytes, and in the filtrate, we increase them, okay? So same thing with thiazide diuretics, we've discussed this. These ions, they travel downstream. So here we're only in the ascending loop of Henle. It goes towards the descending loop of Henle, the DCT, and eventually ending up in the collecting duct. So here in the collecting duct, we have the passive movement of sodium, potassium, and protons, okay? So sodium is the main driving force for this passive movement. So because we have an increase in sodium here, then that sodium obviously wants to move into the cell, to increase, that increases the sodium into the cell, and this creates a positive charge inside the cell. And that means that this increase in positive charge makes other positively charged ions want to come out. So here in the luminal side, we create a negative luminal charge because sodium is coming in, and that means that potassium and hydrogen, they want to come here to neutralize this negative charge, and they want to avoid this positive charge here created by the sodium. So now we have an increase again in potassium in the filtrate, an increase in hydrogen in the filtrate, leading to alkalosis again because of the loss of the protons, and leading to hypokalemia because we're losing our potassiums again. Right, I just want to stress this point again. So in loop diuretics, we retain magnesium, and more importantly, we retain calcium in our filtrate, which means we get hypercalciuria and increase in magnesium in our urine. So if we have lots of those in the urine, it just means we have less of them in our blood. So this effect is basically the opposite of thiazide diuretics, because in thiazide diuretics, we increase the absorption of calcium, thereby decreasing, the excretion of calcium. In loop diuretics, very important point to remember is that we increase the excretion of calcium, and then we create, the decrease in calcium in our bloodstream. Right, so let's discuss the major applications of loop diuretics. So first of all, they are primarily used to treat oedematous state, which basically means to, treat edema of any form, any fluid buildup. So specifically, they are used for acute and chronic pulmonary edema, so edema in the lungs. I think it's usually given as IV to quickly relieve, symptoms such as difficulty in breathing for these patients with pulmonary edema. Also because, as I said before, loop diuretics, they produce prostaglandins, which have vasodilatory action, and that can also relieve symptoms of, shortness of breath in patients with pulmonary edema. And it's used in treating other oedematous states, such as, in heart failure, ascites. Basically, if you have fluid buildup anywhere, you could use loop diuretics. So treatment of mild to moderate heart failure, very specific, mild to moderate heart failure. It's also used in the treatment of hypercalcemia. So hypercalcemia is, increase in calcium concentration in our blood, because as we've discussed from the previous slide, loop diuretics can increase the excretion of calcium. So we could give these drugs to patients with hypercalcemia. Okay. So treatment of severe hypertension, especially in hypertensive emergencies. We could give loop diuretics as well, and they are used in hypertensive emergencies mainly because of their rapid onset of action. Right, so adverse effects, electrolyte imbalances, as we've seen in the previous slide, we create hyponatremia, that's a decrease in sodium, hypocalcemia, decrease in calcium, hypokalemia, decrease in potassium, and alkalosis due to decrease in protons. We also create hyperuricemia. So this is the same with thiazide diuretics, the same mechanism, same principle. We create hyperuricemia when we use loop diuretics because they can inhibit or block the organic anion transporters that transport uric acid from the bloodstream into the tubule, which means that uric acid builds up in the body, and that can exacerbate gout and things like that. It can also be adverse events. It can cause acute hypovolemia because, as I said, these are very powerful diuretics, so they could really decrease the fluid volume inside the body. So acute hypovolemia, we need to keep this in mind. It can lead to cardiovascular complications because, hypokalemia, for example, when we have less potassium, that can trigger some arrhythmias in the heart. Ototoxicity. So this mainly applies to ethacrynic acid, as I discussed, 2 slides prior, I think. So ethacrynic acid is a type of loop diuretic that has ototoxic effects. So it's toxic to the ear and the auditory nerve that supplies, the ear. The innervates the ear, sorry, supplies, sorry. And the reason for that is because there are sodium, potassium, and chloride co-transporters inside their inner ear as well. So these co-transporters are not just found in the tubule, they're also found in the inner ear. That's why ethacrynic acid, and other loop diuretics can cause ototoxicity. Contraindications, obviously gouty arthritis, because as I said, they can cause hyperuricemia.